So first of all, we have Dr. Susan Garwood, who is within the HCA TriStar system at Centennial Medical Center. And she's the head of advanced bronchoscopy and national physician director of pulmonary disease for all of HCA nationally. And then her nurse practitioner, superhero Chandler Deeney, who I have the opportunity to work with, is going to be joining as well. Wonderful. And then at Frederick Health, we have Dr. Maurice Smith, who's a thoracic surgeon there and chairman of the Department of Surgery. And he also helps head up the nodule management program there along with Tammy Welch, his physician assistant. So I'm going to let them speak a little bit more about their programs and go ahead and hand it off to them. So take it away, Dr. Smith.
Great, Heather. Thanks. You can advance the slide for me. So first of all, Tammy and I are incredibly excited to partner with Dr. Garwood and Chandler on a topic that we are both very passionate about, and that is getting your APPs involved in your program. I think I speak for both Dr. Garwood and myself in terms of our programs will be nothing without the APP help. So really excited to get on this program. And you'll see at least in our slide deck that I mentioned the word APP about 300 times, and that's intentional. And that's because, again, that's just how important I think the value is for that. Next slide. I've got just a couple of slides on Nodify to refresh for most, but to introduce to some our blood-based Nodify testing strategy. So this is for patients that are noted to have an incidental lung nodule. It can be identified through CT angio's of the chest in the ER. We get some in the upper slices of the abdomen from our GI surgeons. We have a large volume that come from our calcium scoring CTs by our cardiologists. And then when you get these nodules, how do you know which ones to send for further diagnostic tests? Is it safe to keep them there, or should they move towards biopsy? If you look at current test strategy, what it does is it takes the Mayo Clinic calculator or their preclinical assessment, and that's what you see there in that kind of second column. It looks at the patient's age, nodule size, if it's spiculated, in the upper lobe node or smoking history. And then based on that, it gives you a preclinical number that you're looking at there. So based on the percentage, based on the American College of Chest Physicians guidelines, in the extremes, meaning when the high-risk group, we know those should go to biopsy. In the very low-risk group, we know those are safe for CT surveillance. The issue, though, is that 80% are in that low to moderate risk. And the guidelines are very unclear in that group. As a matter of fact, it is in this group where 15% of the nodules that we send to screening or surveillance are cancer, but at the same token, about 50% that we send to biopsy are on benign nodules. So simply stated, in this population, there's more information that's needed. Next slide. And that's where Nodify Lung comes into play. And so it's a single blood draw that gives you two tests in one. It gives you the CDT, which we'll talk about in a little more detail, which is the cancer detection test. That's for your rule in. And then that's negative, it'll automatically reflex to the XL2. And what that is that's the rule out portion of the test. Now, remember that low to moderate risk group, about 80% are in that category. However, by applying Nodify right down there in the middle, you're going to get about 35% that go to that CT surveillance group. No worries. And then you're going to get 5% that move towards biopsy. The important part to know about that 35%, it's in that 35%. By moving that 35% over, we've been shown to reduce relative reduction of biopsies on benign nodules by 74%. So it's a big deal. Next slide. This one is a quick description of the test, but I really want you to focus more on combining the specificity and sensitivity when you use both tests. And so the CDT, again, that's the cancer detection portion. It's a autoantibody evaluator. And again, if you hit on a certain concentration or level of 7 different types of antibodies, that will result positive. Those patients, Dr. Garwood and myself, are taken for biopsy. But look at that specificity, 98%. And then if that's negative, you go over to the XL2. That's our integrated classifier, and it compares inflammatory proteins versus cancer proteins. And it will hopefully reduce your level from that preclinical assessment to hopefully less than 5, but it reduces it to some level. And then that's 97% sensitivity. I want you to focus on that 98% specificity, 97% sensitivity, because as a teaser, we're going to compare that to the PET scan as we go later on. Next slide. So for those of you who heard me speak before, you know very well that I am the Robin to Tammy's Batwoman. She is the boss. She runs the show. I would literally be nowhere without her. Tammy has built our program from nothing to what it is today. Just incredibly blessed to call her a friend and partner in our journey to bend this lung cancer survival curve. Next slide. So how it's going to work is Tammy will discuss the importance of a centralized lung nodule program. We'll discuss the lung nodule program workflow. We'll go over actually how the patient visit works out for us. And then Tammy will go over, at least for the patients that she sees, the Nodify results algorithm. And then I'll jump back on at the end to try to discuss the financial and program impact, because as I've always heard, we know with no finance, there's no vision. So it's very important that we kind of talk about that impact. So I'll let Tammy take it away.
Thanks, Maurice. So he says this all the time, but it's him that started all of this, and it's his support and collaboration with me that's made such a difference and made this such a successful program. So we actually have both programs in one, lung cancer screening and lung nodule surveillance, sort of integrated together. So they sort of work hand in hand anyway. In our office, it's myself, and we have a navigator who is absolutely wonderful with an imaging background, which is a big bonus for me, because she can review images as well as I can to get the ball rolling for these patients. We have a direct line. The patients can call us, mostly for lung cancer screening, but also any nodules that are found. They have our number. They can contact us directly to be self-referred if necessary. As far as the lung cancer screening patients go, we actually schedule the patients to come see me, and I perform the shared decision-making discussion with them instead of waiting for the primary care or asking the primary care to do it. As far as lung rads go, we follow the guidelines when a patient has a positive finding on a lung screening, but we order Nodify as needed for those two. We're very good about keeping the providers updated, the referring providers, and even to the point if a patient is not answering our phone calls to get an appointment made, we contact them directly. Our feeling is when we've committed to the providers to follow these patients, we want to make sure that that communication flow is constant. We have an internal database for our lung nodules. It's a homegrown access database. We're working on a registry through our EMR. And Renee and I both have direct access to all the schedules so that when we need to rush a patient through the process, we can do that very easily. Next slide. So this is our workflow. We get referrals from all over the place. We've done, I think, a very good job of advertising the process and trying to make it easy for the referring providers to get those patients to us. So because of all of that pounding the pavement, we've gotten a really good referral source from it. Again, we have the single database for navigating through the program, and the process that we have implemented. Whenever a referral comes in, or the report that we have that I'll talk about in a few minutes, I review all of the images and triage those patients to make sure that they're going to the right location as quickly as possible, whether it's on my schedule, Dr. Smith's schedule. We have two advanced bronchoscopists on their schedules, just to make the flow a much easier, quicker process to get the patient to diagnosis and treatment quickly. Next slide. And then I always stumble on this one. The Combined Lung Cancer Identification Program is what we call CLIP. That's both programs together that basically I run, but Dr. Smith is our physician leader. Next slide. So we have two ways of getting people into the program, paperwork-wise, I should say. We have, in our system, we have a report that is run every week. Whenever an incidental finding occurs on a CT scan, the radiologist actually dictates a diagnosis code, or an incidental finding code, they call it. And we run a report based on those findings. We vet those images to see who is appropriate for the nodule program. We also have an outside imaging company, Community Radiology, who supplies us with that same information. It's a little bit later. It's not on a weekly basis, but it is helpful in many ways. Whoops, back. The first thing we do when we have a patient that's appropriate for the program, and when I say appropriate, at this point, anybody that has a nodule that's 6 millimeters or greater are the ones that we reach out to see about surveillance. The first thing we do is contact the primary care provider. We thought when we started the program that this was really important to have that communication. They're the ones steering the ship, and they're the ones that know their patients, know their background. And so the first thing we do is reach out to them and say, hey, Mr. Jones was seen in the ER last week and they have a lung nodule. Would you like us to follow it? We then contact the patient if the answer is yes, and generally get them on the schedule. Essentially, we schedule everybody with me, and then I sort of pass everybody out as needed. If there's something that needs, if it's a 6 millimeter nodule, that's going to be on my schedule, but something that's a little bit more concerning, I may put on the advanced bronchoscopist help staff our lung nodule clinic with me. And so I'll make sure that those patients on their schedule, not only to expedite things, but then, they're getting more procedures, which is what they're happy with. At the initial visit, we have a great setup in our rooms where we have a monitor up. So I'm able to go through all of the images with the patients. I tell most of them, it's your anatomy lesson for the day, and go through the whole image. And, most people leave the visit or come into the visit nervous and leave the visit happy because they're like, this was great. It's more information than I've ever gotten. And I'm fortunate that we have enough time to spend with those patients so that Dr. Smith is busier and he can spend his time in the operating room or in the bronch suite. And then follow-up is pretty well established for us. At the time of the visit, the patient walks out of the building with their new order and their new appointment so that everything is set and the flow works really well. Next slide. So this is just a picture of the front sheet of our database. This is the access database that our radiology department started for us. And it has an arm for lung cancer screening as well as an arm for nodule surveillance. Next slide. And this is the second page, which has all the data that we need. But also, if you look down midway down, that says open visit. That is every visit that the patient comes in with, so we can track not only when they were here, but when their next recommended appointment is, their CT. This is the letter that we send to the provider, the primary care providers. If they are within our hospital system, we can send them a message through our EMR, but we have a lot of outside providers that refer patients to us and see their patients are all over town in the ER or in community radiology. So when we're when a patient's noted with a nodule, this is the letter we send. And it works for a lot of different things. For one thing, when we started the program, I was sending these messages out, and it was a really great way to advertise the program because it lists in there exactly what we're offering to those patients and what we're offering to the provider. It's voluntary enrollment, but it's also the concern when we're in a hospital system is any outside primary care providers that the big system is going to steal their patients. And this is a way to say to them, we're not doing that. These are your patients. All we're doing is following the nodule and sending them right back to you. Next page. And this is more of our workflow. So prior to the visit, my navigator identifies all the patients and highlights them for me. And then I go through all of those patients the night before the visit and see which ones I should back up. The navigator actually goes through our schedules and highlights anybody that qualifies for Nodify just based on paper, nodule size, age, cancer history, all of that stuff. She highlights those for myself and the 2 advanced bronchoscopists, just as a reminder for us to look to say, oh, this patient does qualify for Nodify. Let me talk to them or that sort of thing. As much as I order this test, it is still a situation where I may not remember that, we're so busy. And so this has really been helpful to sort of just remind me that, this is somebody that would be appropriate for that. So once we see the patient, we put a workload, or I'm sorry, once we look at the patient's information, we put a workload in to tell the staff to put that order in. Then at the time of the visit, after discussion with the patient, we actually then put the order right into the portal. We do, we're spoiled and do home phlebotomy still for all of our patients. And so it's been a great patient satisfier. I think things are changing, and we'll have a lab here in the building that will make things easier for everybody involved. But when the patient walks out the door, our reps have done a wonderful job of putting a folder together with information on the test, information on the phlebotomy services, and then all the financial information at the back of it, in case that comes to that point when after they've been tested. Next slide. And then this is our post-op follow-up. That we get the results through the portal and via email. And all of my patients, I contact myself regardless of their results. Dr. Smith has 2 nurse practitioners that work with us on the inpatient side who will contact all of the less concerning results, the negative CDT and the indeterminate results, but he contacts the patients that are CDT positive and indeterminate, because those are the ones that are more concerning and likely will need a biopsy sooner rather than later. And then we also give them a copy of their results in color at the next visit. Next slide. And then we'll move on to the algorithms and what we tell the patients in the script that we tell the patients, regardless, whatever their result is. Next slide. So this is sort of my wheelhouse right here. When I'm vetting these patients, these are the patients that are generally on my schedule, somewhat to the advanced bronchoscopist, but these are the ones that are going to be followed in some way, probably if they're small, longitudinally with me versus one of the docs. And so anybody that we order the Nodify on, if their CDT is positive, we go right to PET and probably biopsy. It takes a lot of factors that are involved in it to decide if we're going right to biopsy. And so that usually what I'll do is order the PET and schedule them for a follow-up with the provider, with the physician, because they're the ones that are going to determine whether or not they're going to do the biopsy. If they are indeterminate, but with a negative predictive value of less than 90, which is kind of lower on the scale of the XL2 result, we generally order PET with biopsy or PET with short-term follow-up with 3-month CT. So if that PET is negative, we may not go right to biopsy in those indeterminate patients, but we follow them much more closely than Fleischner recommends. If they are sort of mid-range for that XL2 result, then we sort of use our clinical judgment. Some people get a PET scan, but the longest we will follow them out is generally 3 months if they're mid-range there. And then the likely benign patients are the ones that I follow through with Fleischner. Anybody else, I sort of fudge Fleischner based on that Nodify result. Next slide.
As always, Tammy, thank you so much. So what you noticed on that initial one was that we do not do PET on nodules that are 8 to 12 millimeters in size. Instead, we get Nodify first, and that helps us determine for a couple of reasons. One, our patient population, it's the PET scans can be expensive, and it's just a lot of resource times in trying to getting certification. But this is the data that helps us back that up. So I know it's a little complicated, but what you're looking at, if you look at the dotted line up top, the dark out gray, what that is that's the negative predictive value of 95%. Then what you're looking at is you're looking at that second dotted line is the PET scan. And what you'll notice is that PET scan actually never gets you to the negative predictive value of 95%. Now compare that to XL2 in the red, and you can just see with the area under the curve how much well it works as opposed to PET scan. Now the reason that is, and this is where I'm going to see anybody was paying attention. If you remember, the specificity and sensitivity for Nodify when you combine both tests were 98% specificity and 97% sensitivity. Give me one more click, Heather. So with PET scan, if the nodule is large and the nodule is solid, it's reasonable, right? It's 87%. However, when that nodule starts getting smaller, 10 millimeters, you can go ahead. With 10 millimeters, it drops down to 51 and 69%. But the next one is my favorite, and Dr. Garwood knows this well. When it's non-solid, that PET's a coin flip, right? And this is the one where we get a lot of those ground glass. They're lipidic pattern. They don't pick up on PET, but they actually are one of those. I'm older than all y'all on this call, so we used to call it bronchoalveolar carcinoma. But right now, I think they call it adenocarcinoma in situ. But anyway, that's where you get a lot of these tumors, and that is really where this test, I think, performs well. Next slide. We won't waste time going through this, but just know that, for the nodules that are bigger, we do use PET. We combine PET with Nodify and pinning those results in terms of what we do, especially in the Bronx suite, because I'm not as talented as Dr. Garwood is. I actually use my information to kind of know, hey, I should spend a whole lot more time trying to get my diagnosis as opposed to, hey, this one was likely benign, even though it was PET positive. The patient was concerned with the biopsy, but I'm going to spend most of my time getting cultures and not spending a lot of time waiting for pathology to get our results back. So next slide. So this is something that we had to come about because, as Tammy mentioned for you, where I make our program monies in the operating room, and then also to some degree also in the Bronx suite. So we get a lot of Nodify results back, and I had to use the aid of my nurse practitioners to actually tell them how to talk through the results. So now Tammy is just as experienced as I am, but this was really more for our nurse practitioners. It gave them confidence to try to talk through the results with the patient, and it gave us a uniform talking track to discuss with the patients. The other thing that's been helpful, though, is Tammy and I kind of do this talk, and it's available to you, but it's also helpful to new providers who are using this test to kind of explain it to their patients, right? So I'll take a little bit of time to go through this first one. So, and I'm a simple boy from North Carolina, so I keep everything color-coded. So as you notice on that first one, it was red, right? That CDT positive. CDT positive, we tell the patients, you know what? Your blood picked up on possible tumor antibodies. This doesn't mean that you definitely have cancer, but suspicious enough, we're going to move towards biopsy and also perform a PET scan. If it's CDT negative, we're jumping up and down, we're hugging, because I like this result more than I like any result. Why is that? We're able to tell the patient, you know what? We're still going to continue to follow this. We're going to follow by flasher guidelines, but there's so much less anxiety you have to have. And I see Dr. Garwood shaking her head. Like, it really matters to patients. Like, you can literally see the relief that they get when you're able to give them a likely benign. So I think that's just as important as the CDT positive. Next slide. Now, this is the one where everyone, I think, needs this slide, right? This is where we're really kind of getting into the details of the test. And I'll say this completely is off the second page where Tammy was talking to you about kind of the top portion, the mid portion, and the bottom portion. And what that is it's all negative predictive value driven, but every result on that XL2, I think, and I believe Dr. Garwood does as well, gives you some information you can use, right? And so when it's in the dark, which is in that top box, we say, hey, there's no level of tumor antibodies, that's great. And when we look at the ratio of inflammatory proteins versus cancer proteins, we're able to reduce your risk a significant amount, because usually this risk will be the one that's reduced less than 5%. And this is where I say, you know what, based on that, we're confident and feel comfortable observing the nodule, but we'll do routine scans. Now, just like Tammy mentioned to you, when it's in this middle group, so I call the dark green significantly reduced, the light green slightly reduced, and then I call that yellow non-reduced. I mean, I hate the word indeterminate. It makes you think the test doesn't have value, so we call that one non-reduced. But at any rate, for that middle group, we tell them, you know what, no level of tumor antibodies. However, this test lowered your risk, but not enough for us to feel comfortable waiting a long time to follow up. We're going to follow up with a closer follow-up. And then in the yellow indeterminate or negative value of 90, we say, hey, out of a group of 100 people that had your test value, 30 had cancer. Do you want to observe or go for biopsy? We have not had one yet that wanted to observe. That's a big number. You're making it real to patients. What that's based off of is that is from the data from the Panoptic trial, showing that 30% of patients with that indeterminate result end up having cancer. Next slide.
Oh, sorry.
Are you good?
Is it advancing?
Not quite yet.
There we go.
There we go. Great. So now in this last little bit of 5 minutes, I definitely want to give Dr. Garwood and the team time to discuss theirs. We'll go through kind of the financial and program impact that, again, for NISA, my program, it's a AP-led, right? Sorry, next slide. So this is the star. So we call this the star of Tammy, right? So what you're looking at is you're looking at our program over a 3-year period, And in 2018 and 2019, I'm banging on doors. I'm going door to door. I'm talking to anybody who will listen to me. And you see the success I'm having, right? Lung cancer screening, I get about 14, and then 128 in 2019. Incidental nodules, because we didn't have a good system to follow them, it was very low. But that star, March 2020, and look at the big jump between 2020 and 2021, right? That's just having somebody with the ability and dedicated to get your workflow down, identify any deficiencies, because that big jump primarily was because we weren't tracking or labeling the incidental nodules right. But you just see the big, huge, amazing jump we've had. And again, that is all AP driven. Next slide. And give me one more click. Now, this is what we notice. Again, you notice Tammy's title is coordinator. The reason why we call her coordinator is that means I can ask her to do all of it, right? So she was lung cancer screening coordinator. She was incidental nodule coordinator. She actually saw patients as well. She sees patients. What we notice is when we only had Tammy, that, you know what, about 50% of her time was spent on administrative things. And what that was doing was that was slowing down the volume. However, we did want to show you this because there is volume and there is revenue just based off patients' visits. So we were getting up to about 78 visits a quarter. And again, this is the very beginning. That number has far surpassed that now, especially we've grown to the point to now, Tammy, for a while, had to see patients 3.5 days a week, but now we've got the advanced bronchoscopist 1 day a week, but now we're even getting them more. So again, if you really get your nodule program down, the volume is definitely going to come there. Next slide. And this is it, right? So the beauty about our program is I'm able to actually link, hey, by investing in Tammy, by investing in Renee, there's actual value to the hospital system, right? So I'm able to link it from the beginning to the thoracic surgeon aspect of it. And what you're looking at, you're looking at my nav bronchs almost doubling. Same with EBUS. Robotic lobectomy, this is interesting, right? So I've doubled in that year 2022. I plateaued in 2023. And this slide is what I took to the administration and like, look, I have the work here, but I can't be two places at once. And this is the slide that actually allowed me to hire our 2 advanced bronchoscopists. You're good, Heather. Next slide. And this is our money slide, right? And I know Dr. Garwood has one as well. So what we're taking a look at is you're taking a look at in 2018, and this is for our whole population of Frederick. We serve about a population of 225,000. We looked at our cancer registry. In 2018, we were 29% stage 1, the vast majority being stage 4. By integrating our program, and our program is we definitely use IAM, but we use IAM, we use Nodify, and by having a definitive clinic, this is what the results we've had. So we were able to move stage 1 to 40%. If you look at stage 2 and combine the two, we're at 50% for a whole community. Next slide. And this is just a different graph on that. What this is showing you is that in 2018, without our CLIP program, that stage 1 was about 28%. And then for the whole entire community, it was stage 1. But this is the real fun. That second half of the graph is showing if you actually compare that 2022 population and look at the patients we saw through our program and the ones we didn't. In that very last column, you see we basically flipped that stage curve on its head, right? Stage 4 is the smallest, stage 1, 66%. So again, just showing what could really be accomplished by having a APP-led program, right? Because they have the time to go through the nuances, but also incorporating Nodify. And I would say incorporating it really religiously. So at this point now, it is indeed an honor to pass it over to my sister in arms in the battle against lung cancer, the great Dr. Garwood. We're in for a treat as she and Chandler will share their amazing case presentations and go through our program's workflow and results. So take it away, Doc.
Thanks so much, Maurice. So again, we want to give you a little bit more of a flavor today, and I'll start with just the overarching need that arises. So if you go to the first slide here, you see within HCA, we really are looking at trying to identify nodules on the incidental and on the screening side. And if you just want to think about the sheer volume, we can't as providers do this by ourselves. So without our APPs, we are nothing. And so we leverage software within HCA to identify nodules, much like Dr. Smith and Tammy's does. We look at 6 millimeter or greater nodules. And this is an example. In 2022, we overread right at 3 million scans that had a portion of the lung in the field of view. 8 to 10% of those people that had an eligible nodule had lung cancer. That equated to 3,500 lung cancers that we detected based on incidental navigation only, finding it with natural language processing it, putting it through this clinic process, utilizing APPs, utilizing advanced bronchoscopy, 3,500 cancers. That same year in 2022, we screened about 20,000 people but we only had around 200 lung cancers. Remember, adherence for lung cancer is hard. The first time you get scanned, not everybody has an LRAD4 right away. So you have to think about where your attention needs to be. So just want to focus on how important we feel like not only do we want to find it, but we really need to refine the funnel because there's not enough proceduralists, there's not enough physicians, there's not enough APPs. Next slide. So, and this is kind of small and it does not matter. Our workflow looks very similar to what Frederick's shows. So we have both a incidental pathway and an LRAD 3 and 4 pathway that come into our nodule clinic. First, we started by contacting the primary care providers to get permission. Can we see them? Would we, we're not stealing them, those things. We've been around long enough now that we actually contact the patients directly. We communicate with the primary care provider. We've gone through legal and all of those things, but we've been here since 2018 doing this. And so it's a known entity. We do not cross lines. If they are followed by outside pulmonary, if they have a known cancer diagnosis, they're in another health system, our goal is to make sure that patient gets the care they need. And I have nodule coordinators who are doing this pre-work. Once we get into clinic, again, we tell our nodule coordinators very clearly what that patient will require on the day of a clinic visit. Once the patient arrives, I am no longer the first person that they see. They are seeing the APP the majority of the time. So without Chandler, I am nothing. But we've encouraged across HCA to utilize this process. And every time Chandler sees a patient, risk stratification, it's built into our national protocol. It's embedded in our local protocol. He's going through that process, much like Tammy talked about, and verbalizing that to a patient and documenting when should I use Nodify. Next slide. So we think about, people tell me all the time, I know what lung cancer looks like. I don't need your test. I'm a very experienced proceduralist. Let's take this a step back. Okay, maybe you're not the proceduralist, maybe you're not the surgeon, but let's take it all the way back to the APP and say, how do we make an informed decision? Okay, and I want you guys to leave here today feeling empowered about where this test belongs. And I think it's very important for us to articulate what's happening in our provider brain. And this is what's happening in our provider brain. I said it's the Garwood algorithm, but we all do it this way. Okay, we're looking at the history, right? We're looking at what's making our spidey senses tingle. Smokers, okay, strong family history, certain ethnicities, environmental, occupational exposure, our veterans, asbestos exposure. What led up to the CT, right? So I review these with our nodule coordinators every Monday. It's a 48-year-old, IV drug user. Yes, he's a smoker, but his blood cultures are positive, and he's got speculated multifocal pulmonary nodules. Do I need a Nodify test to evaluate that this is cancer first thing out the bat? Absolutely not. Serial imaging evaluation. If you've got an enlarging nodule, please don't sit on it. Please don't utilize Nodify in that scenario. This is not intended for those who have clear clinical risk factors that are worrisome. When you get past history and serial imaging, start with your risk calculation. Again, what I would strongly advise you, do not use Nodify outside of its intended use. It was validated in a certain set of people, okay? So we want you to use it in patients whose clinical risk is less than 65%. It needs to be 8 to 30 millimeter nodules, not a 4 millimeter nodule, not a 6 centimeter mass that you're trying to get out of biopsying because you think it's an abscess. It's not intended for that, okay? And they need to be 40 years of age. Don't do it on a 25-year-old and then call and ask, is this applicable? That was not the validation criteria. Once we do a calculated risk, for me, if the nodule's at least greater than 8 millimeters, I'm going to consider a PET. Certainly if it's larger, like Dr. Smith said, I utilize PET not for nodule, single nodule, or incidental nodule evaluation. I use PET for extrathoracic disease, and I use PET for nodal evaluation. Dr. Smith showed you what happens with size with PET. It eventually gets to where it's just a coin toss. However, there are some cancers that will jump outside the chest or will jump into lymph nodes, even with smaller size. That will sway what I do. So if a patient gets to me and they already have a PET scan and there's liver lesions, I don't need Nodify, right? It's not going to sway my decision. However, if it's just a pulmonary nodule and there's no extrathoracic disease or nodal involvement, that's when I utilize Nodify. But Nodify has some nuance. And that's where I think as mid-levels, we can get into the weeds a little bit and maybe get over our skis and think we can't interpret this test. You absolutely can. Next slide. So for me, mine is just a tiny bit different than Dr. Smith's. And that's because what I don't want to do is miss an opportunity. And I think the talking points that Tammy and Dr. Smith talked about, being able to articulate, if the antibodies are positive, I say your blood is telling me that there could potentially be something there. It is not a diagnosis of cancer. I do biopsies predominantly on those patients. Even if a PET scan is negative for the nodule, it will not sway my opinion. I'm using a PET to look for extrathoracic disease or nodal involvement. If it's likely benign, again, I am utilizing Fleischner criteria, routine follow-up. The middle ground for me and ours, basically, we're both saying the same thing. If it's indeterminate, he said, I think what did you say? Not unclassified, or you're not reduced, either way. So basically what I tell people is that we cannot reassure you, right? Your test basically could not tell me that I'm out of the woods. And that's how we articulate that with our APP. And again, we move forward with biopsy, utilizing that 30%, 35% of people have cancer. I've not had a patient who goes, I'll watch, it's fine. In the reduced risk, we're going to go through some examples on these reduced risk and indeterminate. So you're very clear about how we interpret this and how the APPs message it on our behalf. Next slide. So the test results, again, remember, clear cut is easy, right? So 5% of the time we've got high level antibodies, 10% of the time we have moderate. If you look at the next slide, the XL2, 35% of the time, clear path forward. The problem is reduced risk and indeterminate. How do you deal with that population? I thought it was helpful to have my rockstar APP talk through some cases with these sticky things and then really get into some of the harder things that APPs may have to deal with that are barriers. Next slide. So without further ado, Chandler, I'm going to walk through how we also engage with referring offices to get these patients into the office to begin with, and why he is at my side as we do these things. So Chandler, Deeney, take it away, my friend.
Thank you. Thank you. So initially, our landscape of physicians changed. We used to have a plethora of pulmonologists that would do the workup for us and then essentially get them to us with a Nodify test, with a PET scan. And then our landscape changed and we don't have as many referring pulmonologists. So we wanted to create a workflow that was easier for primary care providers and reach out to people to start the evaluation a little bit earlier. And so how to make it easy. And so we kind of came up with this slide of how we discuss this with primary care providers or new providers to Nodify. And so we always talk about Mayo Clinic and going through that calculator. And then if their risk is greater than 50%, telling them, let's get a PET scan, send them to us. Typically, we can see them next day. We do a lot of visits in our clinic as a televisit. So the patients can stay in the comfort of their home, in the comfort of their community. They don't have to come down unless they want to. And we can share our screens and actually show patients the images, just as Tammy was mentioning before. If they fall between that greater than 5 or that less than 50%, and then they meet that criteria for Nodify testing, we encourage them to order it to further risk stratify. If they do the test and they're not comfortable with the results, we tell them, still send them anyway. And we'll go over the test results with them and talk about what the next steps should be. Based off, if they keep the patients, based off those Nodify tests, if they can reduce the risk less than 5%, and it has a 98% negative predictive value, talking about that sensitivity and specificity, then they can kind of continue to monitor, because a lot of our primary cares right now are being encouraged to keep their patients as long as possible before they refer out, for that fear of, are you going to steal our patients, other things, send them. And so if the risk is greater than 5%, we encourage them just to go ahead and refer to us, and we'll delve deeper into further evaluation. Next slide. So this was when we reached out to some of our local primary care providers, which were multiple APPs led by a few physicians. this was one of the case studies that initially was sent to us. It was a 61-year-old female. She was set up for a cardiac scoring, had a 1.4 centimeter nodule in the right upper lobe, never smoker, no history of cancer, so referred to us before any other testing. When we saw it, we looked at it. Mayo Clinic risk for us was about 30%. So we ordered a PET scan and had them come into the office after the PET scan. Next slide. So after we had the PET scan, there was faint uptake, nothing that just jumped out at us. So it kind of dropped her risk to about 20%. And so when this visit happened, it was actually a televisit with Dr. Garwood. The patient was real hesitant. She didn't want to pursue biopsy. She had mentioned that she had seen this nodule before, but could not produce imaging, nor could we reference any prior imaging to say it was there 6 months, 2 years, 4 years prior. And so we used Nodify as a tiebreaker. And we basically told her up front, if we can lower your risk to less than 5%, we're more comfortable with watchful waiting. If not, we would recommend biopsy. So she kind of had that in the mind before she left. And we set this up with the APP at her primary care and her community to have it drawn. Next slide. So when she had it drawn, this is her test. And so her pretest risk was 29% and no significant level of autoantibodies. So then it kicked down into that XL2 portion, which reduced her risk to 18%. But the issue for us is when we get below that 95% mark, or for her, the reduced risk of 90%, her sensitivity was only 55%. So it's a flip of the coin that this even reduced her risk at all. And so after this result came in, the APP and I actually FaceTimed together, and she said, walk me through this test. And so I walked her through the test and what we would recommend. And she said, excellent. Do you want me to call the patient or will you call the patient? And so I said, we'll take care of it all. So we actually called the patient immediately after I got off the phone with her. And then we went through this test the same. And basically, when we went through the test with her, we talked. Your CDT was negative. And she was like, what does that mean? And I try to break it down based off educational level or understanding. And so we didn't find any abnormalities in the blood that could be considered cancerous. And so it kicked it down into the second portion where it was able to reduce your risk. But when looking at it, I don't know that it truly did. It gave us a 55% sensitivity. And so again, that's a flip of the coin for me. We recommend biopsy. And she said, well, Dr. Garwood had already talked to me. If it didn't get below 5%, that's what she would want. And so she had teed me up. And so we got her test back on July 31st. On 8/6, the next slide. On 8/6, she was in the endo suite. We had already had a pre-procedure discussion visit, and she was positive for adenocarcinoma, and immediately got her referred to thoracic surgery, and she was resected on 8/30 with a stage 1A2 non-small cell cancer. So within that time frame, less than 30 days, we were able to get her treated and resected. So her blood test influenced our behavior about how aggressive we can be. And when I'm having conversations with patients, I basically tell them this test is going to allow me to say, I need to be a little bit more aggressive. Maybe I need closer imaging. Maybe we need biopsy, or hey, that surveillance image that we've tentatively set you up for, we're good for that. And so then we kick into the next slide, next patient. And so this was a patient from the exact same clinic within weeks. And so 64-year-old male referred because he was not feeling well. They got a CT of the chest for further evaluation. He had a right upper lobe nodule that measured 12 by 9 millimeters, abnormal borders. Mayo Clinic was 46%. The primary care went ahead and ordered the PET scan and then referred down to us after the PET scan had come back. history of an active smoker, family history. His father had head and neck cancer. And so next slide. So he came to us, and with the PET scan, the Nodify test had already been drawn by the primary care provider, but was still pending by the time we actually spoke with this patient. He had an avid nodule in the right upper lobe. So his Mayo Clinic immediately went up to 84.7% just on the calculator. And so this patient, his question was, I was sick. I didn't feel well. I feel better now. You know, is this cancer or could this just be an infection? And so we waited until the Nodify results came back to kind of decide, which was a very short period, to decide which way are we going to go. Even though initially bronchoscopy was recommended, he was also hesitant to pursue it just because he hadn't felt well. And so the next slide. So his pre-test was 46%, no significant level of autoantibodies. So we kicked down into the XL2. Well, it was indeterminate. And so when we spoke to him, we were like, look, this test couldn't raise your risk. It couldn't lower your risk. Just with one calculator we use, you're 84%. We're recommending biopsy. And what's so important about this patient is the next slide. This guy had small cell. And so by the time we diagnosed, immediately got him to surgical resection, it had changed from 14 millimeters to 2.1 centimeters within a couple weeks. And so we were able to resect a stage 1A3 small cell cancer and get him referred to medical oncology for adjuvant treatment in 19 days. Why that is important is time, because if we would have surveillance CT'd in the 3 months, we could be looking at a mass with spread to other areas. Whereas with this person, we made a huge difference in his life. And so the next slide is Dr. Garwood, and kind of where we talk about that 50-50 PET.
Thank you, Chandler. Yeah, I mean, I think, again, we're trying to show you some of the harder cases, but one of the questions Heather often gets me is kind of, have you had an aha moment? And I think that I know what cancer looks like is always the one that gets me. And we were bred on PET scan, right? That we live and die based on that PET result. And that should sway our opinion. Like that last patient, when they ask you very clearly, I mean, the PET report says it's cancer until proven otherwise. I just wanted to highlight something that was one of my aha moments. Again, this is the integrated HCA care continuum. 57 ER incidental finding, had chest pain, so no pulmonary symptoms, and had a pretty scary looking spiculated nodule in his upper lobe. Heavy smoker, 60-pack years, no family history of cancer. He was flagged by our finder. He was captured by our nodule coordinator. He was navigated to our clinic. Next slide. So I see him and he's 45%, right? And so that's pretty high. Makes me nervous. I am in the thoracic surgeon's office, no offense, but my thoracic surgeon said, I also know what cancer looks like, and a chance to cut is a chance to cure. And let's get a PET scan and see what it shows. So we get a PET scan, and the PET scan's positive. And he said, see, yeah, this looks like cancer. There's nothing anywhere else. I'm going to take him to the operating room. And I said, well, we have this blood test. This is in 2020. Why don't we see what the blood test shows? I can reduce his anxiety. And so we get the blood test, and the blood test result comes back. And it says no antibodies, likely benign, right? 98%. However, at the same time I had this conversation with the patient, the surgeon also said, but what if it's wrong, right? What if you're that 2%? It's at the edge of the lung. It's totally fine. You're not going to lose that much lung. Everybody does great with thoracic surgery. You won't miss it. Next slide. So he gets resected, and it's a granuloma. Okay. And I think the one point that Tammy and Maurice and Chandler and I all feel strongly about is if you get into a regular cadence of using this and look at all these different scenarios, think about that 98% negative. I would have kept following this patient. Okay. I'm not going to drop these people, but you have to be able to eloquently talk through the results, use the data strategically to talk them through all the scenarios that this test can lead you through. But again, this one for me really hinged on PET is not a perfect test for solitary pulmonary nodule. Great for nose, great for extrathoracic disease. Next slide. And so I wanted to also share one of the other things they think, if we think about 35% of the time, it's going to tell us not to act. And in most of the studies, that's 45%, where it tells you not to act. And people worry, well, I'm a proceduralist, why would I want to curb the amount of procedures? I know what cancer looks like. I'm going to go ahead and take these people when needed. What I can tell you is I've been using this test routinely since 2019, and you can see our volume has grown. We are projected to do 1,300 bronchoscopies, just me and my partner. And I can tell you, as you grow, this is coming. You cannot do this without mid-level support, okay? They feed it. You guys need to be an extension of each other to make this possible. And the most important side for us is on the next slide, is what happens to these patients from a stage standpoint. And this is all comers, not just what's happening in my specific clinic, but all comers within my hospital. We've been able to shift the stage to 48% stage 1 all comers, okay? And that's massive. That's everything that you want, is to use every tool in your toolbox. And if you don't think that you need this test, I would encourage you to look at your stage, see if you've had these results, see what can be possible with integration. And as mid-levels, know that your impact is so important. Look at what Tammy did in CLIP. Look at what Chandler's helped us do here. But this is everything we're looking for. And we cannot do that without empowering the APPs and empowering health systems to think outside the box. Put your procedures in the lab. I mean, Dr. Smith he's a unicorn, right? We don't have surgeons who say, I'm just going to feed myself because it's the right thing to do. And he did that, and he's grown, and now he's got APPs, and now he'll be able to break up with bronchoscopy. But I mean, you got to think outside the box, and we can't do that without the mid-level. So we wanted to talk you through some of the challenges too, and some of the more of the nuances with APPs. Next slide. So I think, Chandler, you and I had just a great dialogue yesterday. So maybe kind of go through some of these things on some of the barriers folks on the phone may encounter during this process.
I get a lot of kickback, and I'm used to it, about I would rather see the doctor versus a mid-level. Maybe I've had a bad experience. Maybe that's just what they prefer. Even some providers prefer the doctor. And so in those instances, we offer them those opportunities. Now, with them doing more bronchoscopies, that limits their days in the office. And whereas I'm there Monday through Friday, when they go through the ER and, they've got chest pain and they get that CTA of the chest to make sure they don't have a PE. And the ER doctor says, we found a nodule. It looks like you have cancer. You need to have that evaluated. But they're never left with anything. So then they're anxious. So they get contacted by our coordinator to our office. And then I get on the phone with them. Well, I want to see the doctor. Well, it's Thursday afternoon. Her next clinic day is Wednesday. And so I can see you tomorrow if you would like. Most of them are okay with that. And then as we go through the kind of the process that Tammy had mentioned earlier, very similar workup. Our offices are almost identical. We go through all the images, not just the CTA that was done before, but if there's any image that was done prior, we will compare it right there with them, so that we've developed a timeline. We've got a good history. Not all the patients like it, but we do the Mayo Clinic with them and explain what we're looking at. And then from there, we create recommendations, and that eases their concern a lot. Access to us is just easier. They're wanting to be proceduralists, which is what they've been trained to do. And we enjoy doing what we do. And so it's just easier. A lot of patients don't trust the health system. And that's over the past couple of years. If you haven't noticed it after COVID, that it really changed how they trust healthcare providers with a lot of misinformation. And so getting them then, being honest with them, and just having a good conversation, and not just having a good conversation, but having a conversation on their level. Those are some of the things that we can kind of run into and kind of go from there.
Yeah, I think the anxiety part, I think after a patient has an experience with our office, our coordinators, our APPs, that patient satisfaction is the best advertisement we have. They go back, they don't feel rushed, they feel heard, they feel reassured, they feel informed, and those are our best selling points. And I got to tell you, Chandler does it better than me, right? He's not rushed. He has more time. His schedule is not full, but he's saying the words and spending the time I wish I could, with every single patient. I just don't have the bandwidth. And the level of anxiety, they come with preconceived notion. The ER doctor has already told me cancer is present. The report already says it's cancer until proven otherwise. The patient can get completely off track. And those can be circular conversations. And it's so important to have your APPs be able to do that. The current state of recommended nodule follow-up also is a tricky one, right? Because when we ask physicians what their plan is, they're going to tell me I'm going to follow Fleischner. And Fleischner says 3 months, 6 months, PET or biopsy. And what we say is, man, we're the easy button. You can text me, you can text Chandler. We can help you identify this. We can help you reduce liability. We have clear impact on patient outcomes. We can get in depth with this. You don't have to do any heavy lifting. Call me anytime. And by call me anytime, they call Chandler probably more than they call me because they know that they're going to get a judgment-free evaluation. Who needs to be seen, who doesn't. And if it needs to be seen, he'll say, put them on. I can talk to them in an hour via telehealth. And that ease of access is very important. Next slide. And I think the difficulty understanding how to discuss the results of patients is what we wanted to get across. Building that rapport, meeting them where they're at, developing your script, being very clear, basically almost red, yellow, green, like which one, where are we? Let's break it down very simply. Showing the images really garners trust, catering the discussion to the educational level, the patient's biases, prior input from other providers. They may involve you in a litigious conversation. I've been following by a pulmonologist who's only ever talked about sleep medicine with me. Why did I never get screened before? Why did I never get offered this? Why, did they not say that they saw something on an x-ray? These are hard things to get out of, and APPs are perfectly capable of diverting that patient and getting them back on track. And I think the one last thing I want to leave you with is how valuable the APP is in the whole care continuum. We talked a lot about the pre, but I cannot do my job with stage shift. We talked about continuity of care. We wanted to highlight that timeliness. That also involves the APP. Helping communicate results, helping coordinate referrals to next steps. Okay, that small cell needed a brain MRI. They needed a medical oncology conversation. They need to be into PFT and surgery yesterday. Chandler is helping work through my office with that. At his prior job, why I snagged him, Chandler presented all of these to tumor board. He ran all of it, stem to stern, and that part is huge. So you can insert yourself and truly integrate into the larger care team. But we wanted to empower you today. We wanted you to know teamwork makes the dream work. And we're so proud that all of you just jumped on tonight. We appreciate you all.
Thank you all for such valuable information. I think this was really incredible in terms of just nodule management and really how to build a program and leverage the additional capabilities you have with your APPs.